Hello, my name is Heather Disney, and I'm a physical therapist at University of St. Augustine. Thank you for taking the time to allow me to speak with you today. Did you know that whiplash is one of the most common injuries associated after a motor vehicle accident? In fact, a recent study by Polison et al. 2019, published in the Biomed Central Journal, found that over 50% of people complain of some form of cervical pain after a motor vehicle accident. The purpose of this case report is to share an interesting patient I recently treated and to demonstrate the effectiveness of physical therapy in treating whiplash associated disorder. The patient was a 27-year-old female presenting to me for physical therapy 5 days post motor vehicle accident. She reported after the initial injury she felt fine, but the following day she had severe neck pain, so bad that she went to the emergency room. There, she was prescribed Flexerol and naproxen, given a soft collar, and just told to rest. She reached out to me and came into my clinic through direct access a few days later to see if physical therapy could help. I had treated her before for previous injuries, and she had responded positively to physical therapy in the past. She reported this dull, achy pain around the lower cervical, upper thoracic region. And on the numerical pain scale, her symptoms ranged from 2 out of 10 to 8 out of 10. Usually her pain was lower in the morning, higher at the end of the day. The numerical pain rating scale is a 0 to 10 rating scale, ranging from 0 being no pain and then 10 being the worst pain imaginable. According to Hermstead et al. 2011 in the European Palliative Care Research Collaborative, the numerical pain rating scale has been shown to be a valid and reliable way to monitor a patient's pain. As far as outcome measures, the Neck Disability Index was used as the primary outcome measure to monitor functional progress. This is a questionnaire regarding things like pain intensity, patient's ability to sleep, drive, work, concentrate, and do simple personal care activities. Shin et al. In 2017, published in the Journal of Exercise Rehabilitation, determined that the Neck Disability Index was a valid and reliable tool for monitoring patient outcomes. Now, the patient's goals were simple. She wanted to be able to return to work, to drive, and to take care of herself independently and without pain. So she presented to me in a soft collar with moderate forward head posture and a thoracic kyphosis. She demonstrated limitations in active and passive range of motion in all directions of the cervical spine, most notably flexion and right more so than left rotation. Passive intervertebral motion testing was used to assess the mobility of the individual joints. This revealed hypermobility or increased motion at the C4-5 and C5-6 levels, as well as hypomobility or decreased movement from C7 to C7T1 to T3-4 in that upper thoracic region, as well as the T4-5 to T7-8 in the mid-thoracic region. The neurovascular screen was negative. Patient didn't have any radicular symptoms, didn't have any dermatomal paresthesias, there was no myotomal weakness, and her reflexes were normal. Shoulder mobility was relatively normal except for some limitation in end range shoulder flexion that was limiting her ability to do functional tasks such as reach overhead into cabinets. Upper cervical ligament integrity was normal, and her open mouth radiograph done in the emergency room had been negative. There was also trigger points, increased muscle tone, and corresponding tenderness noted in the subcranial musculature, as well as the levator scap and the upper trapezius muscle. Palpation to these areas also reproduced many of the patient's symptoms. Further strength testing revealed significant weakness in the deep neck flexors, and this is a major muscle contributing to stabilization in the cervical spine. So based on the mechanism of injuries, subjective and objective findings, the patient's physical therapy diagnosis was a cervical strain. Patient's prognosis was excellent. She was young, healthy, motivated, and there was no significant past medical history. The patient's long-term goal for physical therapy was to be able to restore at least 75% active range of motion, pain-free, improve her deep neck flexor strength to within normal limits, and eliminate any hypomobilities in the cervical and thoracic spine so that she could return to her normal activities. Now, overall, the primary impairments and corresponding interventions go as follows. There was hypomobility in the upper thoracic and mid-thoracic regions, everything from C7, T1 down to T7-8. The appropriate treatment for all of these is manipulation, including thoracic thrust manipulation. According to Hides et al., published in the Spine Journal 2001, there was demonstration of manipulation to be an effective treatment for managing cervical pain. There have also been correlations between limitations in thoracic mobility, preventing full overhead shoulder flexion, which this patient was also suffering from. Clinical reasoning suggests that mobilizing the thoracic spine before initiating treatment directly to the shoulder should be utilized. Other impairments include hypermobility at the C4-5 and C5-6 segments. Treatment here was deep neck flexor strengthening and other cervical stabilization exercises. Again, Joel in 2002 in the Spine Journal demonstrated successful stabilization techniques using a blood pressure cuff for biofeedback to improve deep neck flexor strength and reduce cervical pain. Lastly, the increased tone, trigger points, and tenderness were treated with myofascial release techniques, including soft tissue massage, trigger point release, and strain counterstrain techniques. A recent study by Rahim and Seffinger in 2015, published in the Clinical Journal of Pain, showed positive outcomes with myofascial trigger point release. Once these impairments were addressed, other impairments such as tightness in the upper trap and tightness in the levator scapula were more noticeable. These were treated with manual myofascial techniques, followed by sustained self-stretching as part of the patient's home exercise program. This patient was seen for 8 visits over 6 weeks, and had an overall positive outcome with early physical therapy interventions. All impairments were able to be corrected. As stated earlier, at least 50% of people suffer from whiplash-associated disorder post-motor vehicle accident. Of that number, some go on to develop long-term chronic pain. This patient was able to receive physical therapy soon after her incident, and thus we were able to manage her symptoms quickly, conservatively, and successfully. Her neck disability outcome measure improved from 45 down to 10. She was able to return to work driving, and activities of daily living were pain-free. This is just one of many cases I can tell you that have had a positive and successful outcome with physical therapy treatment. Please consider physical therapy as a conservative first line of defense to treating many common musculoskeletal related injuries. I appreciate your time, and I look forward to any questions you may post below.